When in pregnancy do most abortions occur?
Most abortions occur early in pregnancy, particularly prior to 12 to 13 weeks.
And do you know if that's true in Florida as well?
Yes, that is true in Florida.
What are the general methods of abortion?
Generally, there is a medication abortion, which is a medication regimen that induces a process similar to miscarriage, and then an in-clinic or procedural, or sometimes called surgical abortion, which is a procedure performed in the clinic.
And what are the common methods of abortion after 15 weeks?
After 15 weeks, women only have the option of an in-clinic or procedural abortion.
Now, you mentioned that an in-clinic or procedural abortion is sometimes called a surgical abortion. Does it involve an incision into the patient?
It does not.
Is any sedation or anesthesia required?
It can be offered, it is not required.
And can you just briefly describe to the court the counseling or other conversations that you have with patients prior to an abortion?
The counseling provided is quite extensive. First and foremost, we ensure that the patient is there of her own free will, that she is there of her own choice. We date the pregnancy based on ultrasound, and based on that, we discuss her options for medication or in-clinic abortion procedure. Depending on which one she chooses, I review in depth what to expect during the procedure, the risks, the benefits, the alternatives, post-operative follow-up, reasons to call her or if she has any concerns. And for my own patients, every single patient also has a discussion on contraception options.
And Dr. Tian, based on your training and experience, what is your opinion on the safety of abortion?
Abortion is very safe.
And can you say more about that?
Abortion is a very common procedure. It is a very safe procedure. In all of the different types of abortion, medication or in clinic, the complication rates and as well as mortality rates are very low. Specifically to complications, they are all less than 0.5%.
And Dr. Tian, how confident can you be in your assessment?
I am 100% confident.
And how did you form the opinion regarding the safety of abortion?
The safety of abortion comes from my nearly 15 years of caring for pregnant women, including the provision of abortion services. It is also well understood in well-designed scientific literature.
And can you say something about the number of patients whose health outcomes were tracked in the literature that you considered in formulating your opinion?
Thousands upon thousands of patients.
And I believe you mentioned before that you testified that complications occur in less than 0.5% of cases. Is that correct?
That is correct.
Does that figure apply to abortions after 15 weeks as well?
Yes.
Dr. Tian, based on your experience and training, what is the mortality rate for legal abortions in the United States?
It is very, very low, far less than 1%.
Can you be more specific about that figure if you remember?
It ranges 0.6 to 0.7 per 100,000 procedures.
So that's not just less than 1%. That is extraordinarily less than 1%, correct?
Correct.
And in your experience and training, how does that compare to the mortality rate for continuing a pregnancy and giving birth?
The maternal mortality rates for continuing a pregnancy are higher, and they have unfortunately in the last 10 to 20 years continued to increase. Most recently, the maternal mortality rate for white women in this country is 19 per 100,000 live births, and for black women is 55 per 100,000 live births.
And broad strokes, how do those compare to the risks of abortion?
Markedly higher.
Is it accurate to say 12 to 14 times higher?
Yes.
And how do you know, Dr. Tian?
I know this based on my own clinical practice, being a provider of prenatal care, being an obstetrician, delivering babies, being a provider of high-risk maternal fetal medicine care, being a provider of abortion care, and also what is stated in well-done scientific literature.
And what's the source of the data underlying the scientific literature that you've referred to?
There's a handful. One of the best done studies is one done by Dr. Upadhyay that looked at 54,000 abortions performed in California. This was useful because in California, abortion is covered by insurance, so she was able to pull data that was comprehensive of that state. They then looked at complications, namely ER admissions, 6 weeks after the procedure, and carefully went through gleaned medical records, including looking at ICD-9 coding to see if there was any relations between ER presentation and abortion complications. And based on this review, they found that the complication rates for medication abortion, first and second trimester abortion, were all less than 0.5%.
And the Upadhyay study that you referred to, is that Ushma Upadhyay incidence of emergency department visits and complications after abortion that is referenced in your declaration?
Yes.
Taking a step back from that specific study, doctor, when you talk about the comparison rates for mortality for abortion and for continuing pregnancy and giving birth, what is the source of that general data?
Several studies, but most commonly a study performed by Dr. Grimes that evaluated abortion mortality during a specific time period compared to maternal mortality.
And is that the study by Raymond and Grimes, the comparative safety of legal induced abortion and childbirth in the United States, also referenced in your declaration?
Yes.
And in general, are the statistics for mortality tracked by the CDC?
Yes.
And what can you say about the quality of that data?
It is quite excellent and quite comprehensive for how heterogeneous and large of a country that we are.
And are there additional sources of data tracking as well?
Yes.
And what are those?
The Guttmacher Institute, which is a research institute focused on abortion and contraception care, both domestically and internationally, tracks data. There are also local and state level maternal mortality review committees that are committees convened on the local or state level looking at pregnancy outcomes for their particular states for the purposes of safety and quality review that can also be submitted to the CDC or for data review.
Very good. Dr. Tian, one more question on that topic. From your training and experience, how does the risk of death from abortion compare with that of other outpatient procedures?
It is extremely low, and compared to other outpatient procedures, when data has looked at certain time periods, even lower.
And can you think of can you give a rough comparison to other types of common procedures?
Other common procedures that have been looked at include colonoscopy, certain dental procedures.
And is the risk of death from abortion higher or lower than those?
Lower.
Dr. Tan, have you ever had a patient die from an abortion?
No.
Can you think of a colleague who has?
No.
Are you aware of any deaths in any of the health centers that you've practiced in your 14 years of practice from an abortion?
No.
Just a few more questions in this area. Is there any dispute in mainstream medicine about the safety of abortion?
There is not.
Are you aware of any credible studies that show that abortion is not safe?
I am not aware.
In addition to the studies that you've mentioned already, are there other primary consensus study reports or other studies that inform your opinions?
Yes.
What would that be?
Other studies include a very comprehensive review performed by the National Academies of Science, Engineering, and Medicine, which used to be known as the Institute of Medicine, that with convened a group of experts reviewing over 500 articles on the safety of abortion.
And can you say anything about the function of the National Academies?
The function is to glean experts from both fields in medicine, public health, policy, and law to review the available literature, include an intensive look at the methodology of the literature, based on that to weigh the findings and to make recommendations and guidelines.
And what was the conclusion of that process from the National Academies?
Their conclusion is that abortion is a safe procedure.
Dr. Tian, I'm going to shift gears now and talk a little bit about some of the reasons why patients get abortions after 15 weeks. Now, you're here to testify today about HB5. What do you understand that law to do?
I understand that HB5 prohibits abortion at or after 15 weeks with very limited exceptions.
And is 15 weeks late in pregnancy?
It is early in pregnancy. It is within a few weeks of the start of the second trimester.
And how does that relate to the point of viability?
It is at least 2 to 2.5 months prior to viability.
And just to be clear, can any pregnancy be viable at 15 weeks?
No.
Does existing law in Florida allow post-viability abortions, if you know?
It does not.
And do you know if the law prohibiting post-viability abortions is being challenged in this case?
It is not.
Dr. Tian, can you explain just briefly how pregnancy dating works?
Pregnancy is dated by a woman's last menstrual period. Most women have periods roughly once a month. The earliest a woman is aware that she is pregnant is when she misses her period. She's expecting her period and she misses it. And so then she would look back and, to the best of her knowledge, remember when her last menstrual period is. So based on that, the earliest that women can recognize that they are pregnant are 4 to 4.5 to 5 weeks.
And so you said that that would be the earliest that most patients can realize that they're pregnant. Do some patients realize this later?
In my experience, most patients realize pregnancy after that time.
And what are some of the reasons for that?
One of the most common reasons is that many women have irregular periods.
Are there other reasons that come to mind?
Women may be taking contraception that affect their menses. Women may be perimenopausal. They may be breastfeeding. They may have been told at one point that they could not get pregnant. So there are many reasons why women may not realize that they are pregnant early on.
And once a patient realizes that she's pregnant, decides that she wants to terminate the pregnancy, in your experience, how long do patients wait before they schedule an abortion appointment?
In my experience, they call any available clinic immediately.
And why is that?
Because once a patient has decided that she does not want to continue a pregnancy, she wants to be able to receive that care as soon as possible.
Dr. Tian, do you discuss with patients their reasons for having an abortion?
I do. In my experience, they frequently volunteer it.
And in your experience, what are some of the reasons that patients get abortions later than 15 weeks in pregnancy?
I have found that women and girls who need abortions after 15 weeks are those that tend to have the most challenging and compelling life circumstances. They are women that are struggling economically, that may be living in poverty or near poverty. They are women that are experiencing active intimate partner violence. They are women who are less educated and may not be aware that they were pregnant earlier. And they are also women who have intended pregnancies that developed maternal and fetal conditions later in pregnancy.
Dr. Tian, you mentioned patient finances and patients living in or close to poverty. Are those factors that cause delay?
Absolutely.
And can you say more about how, in your experience, that plays out in your patients' lives?
Abortion is frequently not covered by insurance, which means that patients have to pay. And patients already living in poverty or living paycheck to paycheck don't have money available. So many patients are taking the time to raise funds, asking family members and loved ones if they can borrow money. I have had patients who have jobs, just aren't wealthy, but who pull money from their own retirement accounts to pay for an abortion. In doing so, this all leads to delays in care. Many of these patients also have children that they have to care for. We know that approximately 60% of women seeking abortions have other children. And so in coordinating finding childcare, travel, and their own jobs, as well as trying to obtain the finances, can all lead to delays in care.
And is it rare for your patients to be low income?
No, it is the majority.
Are you aware of any statistics on that?
Nationwide, approximately 75% of women live in poverty or near poverty.
And when you say women, is that specifically?
Women seeking abortion, yes.
Dr. Tian, has the COVID pandemic had any impact on delay with patients seeking care after 15 weeks?
Yes, absolutely.
Can you say more about that?
It has caused delays for a variety of factors. First and foremost, there have been shortages in healthcare staff, physicians and healthcare staff who have been out sick with COVID. This has been true for every healthcare system. In addition, patients themselves, due to the aspects of a worldwide pandemic, many of them have lost jobs, face unemployment, and face additional challenges to financing abortion care.
And are you familiar with Florida's mandatory delay law?
Yes.
In very general terms, what does that law require?
It requires that a patient have 2 in-person visits with a physician at least 24 hours apart prior to obtaining her abortion.
And do you have practical experience of that law's impact on patients?
Yes, I do.
And what has that experience shown you?
I have found that practically the delay is actually much more than 24 hours. Most patients cannot take 2 days off sequentially. Practically, for some patients, that delay has led to 3 to 4 weeks between their initial visit and the second visit when they're able to obtain their abortion.
And can you just explain why it could lead to delay up to 3 or 4 weeks? What are the factors that would cause that?
Many factors. Patients may not be able to take off sequential time. Again, many patients have children, and finding childcare is a challenge. Patients may be traveling from far locations and have travel logistics. And part of it is that there is a snowball effect. Abortion in the first trimester is one fee, and if there are delays, obviously the patient is delayed farther in her pregnancy. Abortions offered later in pregnancy cost more due to the expertise that is required, which then compounds the delay as the patient is trying to raise those funds.
Dr. Tian, you testified about patients who are experiencing intimate partner violence. Can you talk more about how that impacts patients seeking abortions after 15 weeks?
So some of the characteristics of intimate partner violence are coercion and control, including sexual violence, forced impregnation, birth control sabotage, either refusal to use birth control or purposefully trying to prevent a patient from using birth control, as well as trying to control a pregnancy outcome. And so in these particular settings, and I have personally experienced this, women who become pregnant, have made a decision to end a pregnancy, and are trying to make an appointment, have to do so carefully without their perpetrator being aware. And so they may only be able to make an appointment 2 weeks when their partner is not aware or out of town. And so in addition to the usual logistical difficulties, they have an additional barrier making access quite difficult for them.
And Dr. Tian, statistically, are patients who have abortions after 15 weeks more likely to be experiencing IPV than patients who have abortions earlier in pregnancy?
Yes, they are.
Dr. Tian, what about struggles with substance addiction? Is that a circumstance that leads patients to have abortions after 15 weeks?
Yes, absolutely.
Can you say more about that?
Women who are struggling with substance use disorders face multiple challenges. Women may be, struggling with the substance use disorder, their own medical conditions. They may be trying to admit themselves to a rehab program, improve their lives, all of which can impede on timely access to care. Women who are struggling with substance use are also more likely to be living in poverty or even homelessness. And you can imagine that being homeless makes it difficult to make a clinic appointment and obtain care.
Dr. Tian, are there certain age groups that are disproportionately likely to have abortions after 15 weeks?
Yes.
Can you say more?
Women who are young and adolescent are much more likely to need abortions after 15 weeks.
And why is that?
For a variety of reasons, women who are young may not realize that they are pregnant. A lot of young women have irregular periods at the start of menarche, which is the start of menstruation in a woman's lifetime. And a lot of young women may be less educated about basic reproductive biology.
Dr. Tian, you testified about some of the factors that cause patients to have abortions after 15 weeks. If HB5 goes into effect, is it plausible that those patients can just come in sooner and get an abortion prior to 15 weeks?
It is not, because the life factors that are affecting them don't just go away. Poverty doesn't just go away. Struggles with substance abuse doesn't just go away. Violence doesn't just go away.
Dr. Tian, do maternal health issues come up that cause a patient to have abortions after 15 weeks?
Yes.
And do you have experience treating patients navigating that situation?
Yes, I have extensive experience.
And do those conditions sometimes arise after 15 weeks?
Yes.
What are some examples, briefly?
Women can have pre-existing medical conditions such as high blood pressure or diabetes that are worsened during pregnancy. Women can also develop health complications directly related to the pregnancy after 15 weeks.
And have you treated patients with each of these conditions?
Yes.
Do these concerns impact any specific population differently than others?
Specific to maternal health conditions, these are far and wide desired, loved, and intended pregnancies where women develop devastating complications at later points and have to make difficult decisions.
And in terms of the patient demographics that experience maternal health conditions during pregnancy that lead to that situation, is that sort of equally distributed demographically?
Though anyone can develop a pregnancy-related complication, it is true that women with pre-existing health conditions such as diabetes and high blood pressure are also women that are more likely to be living in poverty. Indeed, those of us who appreciate the social aspects of medicine would call some of these chronic diseases diseases of poverty.
And in talking to patients about health conditions that they face during pregnancy and how to make decisions about their pregnancy, is that a significant part of your practice as a maternal fetal medicine specialist?
It is the core of what I do as an MFM.
And what are those, just briefly, can you sketch for the court what those conversations usually look like?
As an MFM, I'm usually the one either diagnosing or guiding the care of a woman who has a health-related pregnancy complication. The conversations involve the diagnosis of the complication, how that impacts her pregnancy, how that impacts her delivery, how that impacts care after her delivery, and interventions and options she has to optimize her particular health in that setting.
And part of that conversation is part of that conversation that she decides whether to try to continue the pregnancy or to terminate it?
Sometimes that is a required part of the conversation.
Dr. Tian, I think this is already clear, but just to make sure, if a patient is having an abortion because of a serious health condition, can that patient just come in earlier and get an abortion prior to 15 weeks if this law goes into effect?
No, many health conditions develop after 15 weeks.
Dr. Tian, in your work as a maternal fetal medicine specialist, do you also counsel patients who've received a diagnosis of a serious fetal condition?
Yes.
What are some common fetal conditions that have occurred in your patients' pregnancies at or after 15 weeks?
There can be many different genetic conditions. There can also be structural birth defects, such as in the brain or the heart or the spine, that may not be diagnosed until after 15 weeks.
And are those conditions fatal to the fetus?
Sometimes they are, sometimes they are not.
At what stage of pregnancy would a patient typically learn of such an anomaly?
Some anomalies can be seen earlier in pregnancy. However, in the MFM world, what we call the anatomic survey or the anatomy ultrasound is offered between 18 to 22 weeks because it most greatly captures the amount of information that we are looking for.
And as an MFM, do you have conversations with patients who've received a serious fetal diagnosis?
Yes, I'm usually the one giving them the diagnosis.
And can you just explain for the court a little bit how those conversations play out between you and your patients as they're deciding what to do after receiving that diagnosis?
So first and foremost, these are devastating conversations because these are women with intended and desired pregnancies. They come to me for their ultrasounds and they are expecting good news, and it's supposed to be a joyous appointment for them. So first and foremost, I am throwing a brick at them. I am pulling out the rug from underneath them to give them devastating news. So to the best of my ability, I explain the diagnosis, my concerns, how they can anticipate that diagnosis to impact the pregnancy, potentially the delivery location, as some fetal anomalies do require deliveries at higher levels of care, as well as what they can expect for the neonate after delivery, if there's required surgery, as well as for the development of that child. In part of that discussion, I discuss that there can be that their care will be altered and that it may require additional subspecialty care with pediatric subspecialists. And also as part of the discussion, I discuss their options, namely continuing the pregnancy and parenting, continuing the pregnancy and making an adoption plan, and pregnancy termination.
And Dr. Tan, I think this is clear from the testimony that you've given, but thinking about your patients who are diagnosed with a fetal anomaly either after 15 weeks or shortly before 15 weeks, can those patients just get an abortion sooner if this law goes into effect?
No, because many anomalies are not evident until after 15 weeks.
And what about for the ones that are?
Even in that setting, it is important to remember that these are desired pregnancies, and so patients need time to gather the information to make the best decisions for themselves. So for some patients, it may include seeking a second opinion, talking with other subspecialists, in addition to speaking to their own family members, their clergy, their support person. So patients need and deserve that time to make these decisions.
Dr. Tian, I'm going to shift gears now and ask you some questions about how HB5 would impact the patients you've been testifying about. You testified before that HB5 bans abortions after 15 weeks. Do you know what the penalty would be if you violated HB5?
The penalty is a monetary fine, imprisonment, and loss of licensing and livelihood.
And do you know whether health centers providing abortions in Florida are also subject to penalties if they violate HB5?
Similarly, there are monetary penalties as well as loss of licensing.
And if HB5 goes into effect, would you violate it and provide abortions that don't fall within the exceptions?
No, I would not.
Why not?
Because I follow the law.
And what about other providers, if you've had those conversations?
They will not.
What effect would that have on your patients, Dr. Tian?
HB5 would be devastating for my patients and for the women and girls and families in Florida.
Doctor, if your patients can't get an abortion after 15 weeks in Florida, do you know how far they would have to travel out of state to get one?
Currently, for my patients that are able to travel, the closest location is in North Carolina. That round trip is about 1,000 miles.
And is there another location that's close for some patients, if you know, depending on where they're coming from in Florida?
Depending on where they're coming on in Florida, another option would be Fairview Heights, Illinois.
And is that similar distances?
Yes.
And in your experience, would many of your patients be able to make that trip?
No, they would not.
How do you know?
Again, being able to travel out of state requires time, flexibility, finances, support, a supportive job, a supportive family. That is not the case for most of my patients.
Dr. Tan, do you have experience providing abortions to patients who were turned away from care in other states?
Yes.
Under what circumstances?
As a physician in Oklahoma City at Trust Women, I cared for women prior to and after the passage of SB 8 in Texas.
And can you tell the court a little bit about that experience?
It was profound. SB 8 banned abortion after 6 weeks. Thousands of women traveled to other states as well as out of the country, and many of those women came to our clinic in Oklahoma because we were the closest location.
And what, if anything, does that tell you about what would happen to your Florida patients if HB 5 goes into effect?
I anticipate a similar situation of desperation.
And do you have insight from your experience in Oklahoma as to whether patients were always able to make that trip?
They were not. Patients drove between 6 to 12 hours to see me, drove back that same night. I had patients whose partners lost their jobs because of absence from work, trying to support their loved ones. And these were the patients that were actually able to make it from Texas to Oklahoma.
Dr. Tian, if a patient can't get an abortion in Florida and can't get one in another state, what are her options?
Her options are to end the pregnancy outside the medical system or to continue the pregnancy against her will.
The state argues that HB 5 improves maternal health. In your opinion, is that true?
No.
Why not?
Women who are seeking abortions seek abortions for a variety of reasons, many of which are related to health concerns, pre-existing health concerns. Women who are not able to obtain an abortion will be forced to continue pregnancies, and many of those women will develop high-risk complications that can permanently alter the course of their life. Many of these women will require additional care, hospitalization, as will their neonate. And many of these women will suffer permanent physical, mental, and emotional harm, including death.
Dr. Tian, if a patient, thinking about all of the different reasons you've discussed why patients get abortions after 15 weeks, if those patients end up still being able to travel out of state and get an abortion, but they're delayed and get it later in pregnancy, does that benefit their health?
It does not.
What does it do?
Abortion is always a safe procedure, but an abortion performed earlier is safer and preferable to an abortion performed later.
Dr. Tian, you testified that HB 5 includes an exception for fatal fetal anomalies, but does that alleviate your concerns about how the ban would impact patients with a fetal anomaly?
No, it does not.
Well, why is that?
There are many conditions that may not be clearly fatal, but that can have profound, permanent, and long-lasting implications for the family and for the neonate.
You also testified that HB 5 is an exception for maternal life or serious risk of a substantial and irreversible damage to a bodily function. Does that alleviate your concerns about the effect that HB 5 would have on your patients?
No, it does not.
And why not?
I have several concerns in regards to the maternal life and bodily harm exceptions. First and foremost, in the provision of good medical care, it is antithetical to wait until a patient is so sick and at the cusp of dying before intervening. A good example of this would be bleeding. Women can have bleeding in pregnancy at any point in pregnancy. Unfortunately, for many of those women, that bleeding will resolve on its own. But there are some women in which that bleeding can increase, and for some women, bleeding that becomes so catastrophic that the standard of care is to end the pregnancy. And so depending on the gestational age, either delivery or performing an abortion. And in that particular setting, as a physician, when we start to recognize bleeding, we need to act on it. It is the standard of care to be proactive on acting on bleeding. We know that a lot of pathology is a spectrum that can accelerate within a couple hours, within an afternoon. And so to wait until the very moment in which a patient is about to have permanent complications from bleeding, permanent kidney failure, a heart attack, a stroke, is absolutely antithetical to good patient care. My other concern, and I speak as a physician, is that physicians, we are clinicians, we are healthcare providers, we are not legal experts. And as physicians, we may not be aware of the nuances of a law and the exceptions of a law. And so especially when the penalty is imprisonment, loss of licensing, loss of livelihood, and really loss of a calling, because being a physician is a calling. There are easier ways to make a living. There are physicians, for fear of misinterpretation, or just misinterpretation, that might not act or intervene on behalf of a patient when they otherwise would, because of misinterpretation of HB5, or a concern that their intervention and action would be misinterpreted in a court of law at the expense of licensing and really the threat of imprisonment. So I have tremendous concerns about how this would actually play out in the clinical setting.
Dr. Tan, I only have one more question. Actually, I take that back. I have two more questions. One is, you testified about the impact that HB5 would have on your patients. Can you talk about what impact it would have on your patient-physician relationship?
HB5 directly impedes and interferes on the physician-patient relationship. As a physician, it is my primary duty and professional responsibility to provide evidence-based, scientifically sound, and compassionate medical care. And in the specific realm of pregnancy care and abortion, that includes providing them with all the education, all the counseling, and all of their options, and supporting them in whatever they choose in regards to their pregnancy and their intentions for family planning. HB5 directly impacts on the sanctity and the privacy of the physician-patient relationship.
Dr. Tan, my last question, the state argues that this law should be allowed to go into effect because relatively few patients obtain abortions after 15 weeks. In your opinion, what would the effect of the law be on those patients?
I have two thoughts to that. The first is that even though it is true that most abortions are performed earlier in pregnancy and prior to 15 weeks, we know that women who are seeking abortions and need abortions after 15 weeks are already in compelling and difficult circumstances. And so these are not women that can just get abortions sooner because the law has changed. My second thought is that I provide abortion services at Planned Parenthood. However, there are thousands of women and girls in the entire state of Florida that can develop complications after 15 weeks. And this law would impact them too, not just my patients at Planned Parenthood.
Thank you, Your Honor. No further questions.
Okay. Why don't we take a 10-minute break and then go to cross?
That would give you all.
Okay. We'll be back at about 10 after 11.